May I invite Dr. Ganesh B. Raman? Is he there? He's there. Okay.
Thank you.
So, welcome, Dr. Raman. So, you'll be speaking on the management of neovascular glaucoma.
Thank you, sir. At the outset, I'd like to thank KSOS and Dr. Srini for providing me this opportunity. Can you go to the first slide? Are we good? Thank you. Thank you, sir. So, neovascular glaucoma was first described in 1866, but then it was Weiss et al. In 1963 who gave the term neovascular glaucoma. It's actually a fibrovascular membrane that develops on the surface of the iris and angle, and then contracts, then finally forms a peripheral anti-synechiae, and it's always almost associated with ocular ischemia. And it causes severe ocular morbidity and visual loss. So we all know that vascular endothelial growth factor is the main angiogenic substance, and it's about 40 to 100 times more in patients with neovascular glaucoma in the aqueous humor than other people. And the other polypeptides and proteins have also been enumerated. The earliest rubeosis occurs in the pupillary margin. So many conditions are associated with neovascular glaucoma. Most common in India, as Dr. Subudhi has already mentioned, diabetes mellitus. And then you have other retinal associated conditions, extraocular conditions. And then in ocular therapy, you have a very high chance of neovascular glaucoma developing after cataract extraction, or even vitrectomy after for diabetic retinopathy, even retinal detachment. So the principle of management is to make the hypoxic retina anoxic. So that's what the principle is, and also to reduce the further liberation of VEGF, and also prevent secondary glaucoma and optic, associated optic, glaucomatous optic neuropathy. So the important thing is to access or visualize the retina as soon as possible in such patients. They may be affected with cataract, or they may be affected with corneal edema because of raised intraocular pressure. So access to retina is quite difficult. So our job as glaucoma specialists is to make sure that the retinal consultants have access to the retina to ablate the retina. So you could use medical management, and all glaucoma drops can be used. In fact, we even use bimetoprost in some cases if you are pumping them with a lot of steroids, because it has scleral penetration. And they have irritative iridocyclitis. So there's a vaccine in vein as far as the inflammation is concerned. So on days in which they have severe pain, you can increase the steroids. And always remember, you could use topical glycerin when they walk into the OPD. Usually the postgraduates or fellows will give a mannitol and send the patient to the ward and then call after 3 hours, but that doesn't need to be done. You could always apply glycerin in the eye after local anesthesia and visualize the fundus. So I'll give you some patients whom we manage. This is a 55-year-old male patient with a sudden onset of pain, redness for 6 weeks, and he was operated about 5 months back in the left eye, reduced vision in both the eyes for 2 years, and he had a PRP 3 sittings in the left eye, but he was on glaucoma medication, dorzolamide, combo of prostaglandin and timolol and ROCK inhibitors. He's been a diabetic for 20 years and hypertensive for 10 years. So he had neovascularization of the iris, immature cataract in the right eye, normal intraocular pressure. In the left eye, he had a raised intraocular pressure, pseudophakia, and he had a supratemporal scar, because of which we were hesitant to do a glaucoma procedure. But since his intraocular pressure was 34, and he has synechial angle closure in the right eye, open angle in the left eye. So what he exactly needs was left eye urgent attention to reduce the intraocular pressure. The right eye could wait for a few months. That's how we did it. And we performed a trabeculectomy in the left eye, and then went ahead with the cataract surgery after 2 months after trab in the right eye, provided his systemic condition was under control. So that you can see after about 4 months, he has a good vision, 6/6 both eyes, intraocular pressure well controlled, good pseudophakia. The antiGM in the right eye is slightly shallower than the left eye, but that's acceptable for the present time. And on 3 glaucoma medications, because his trab actually eventually failed, and he had to be on glaucoma medication. So the second patient had a defective vision in the left eye, slowly progressive for 2 years, right eye progressively deterioration for the last 8 months. So he had a documented history of PDR, the left eye is absolute, and the right eye neovascular glaucoma, and he was referred to us for glaucoma drainage device. The vision in the right eye was 660, mainly because of the cataract, and left eye was no PL, intraocular pressure 26 in both eyes, and he had grade 2 PSCC. And in the right eye, and he had laser marks in the right eye, which I think we suspected was not adequate. In the left eye, it was an absolute eye. So this is a gonioscopy angle, right eye is synechial closure. So the problem is that patient is monocular. He needs retinal ablation for PDR because the initial PRP was inadequate and also arrest of the neovascular process. So we planned for combined cataract and glaucoma surgery. Now you would ask for a cynical closure, how would this work? But I'll tell you, this is his right eye. So the important thing is you could plan for a trab in such eyes, mainly because it gives you a very good view of the fundus. The intraocular pressure reduces very quickly. If we had put in a tube, you would have a lot of hyphema. You could have inflammation, which would obscure the vision. A combined cataract and glaucoma helped in this in this situation by providing a clear media, and the examination treatment was expedited. Another patient who walked into us, were referred to us for left eye neovascular glaucoma, had extensive neovascularization of the iris in the left eye, open angle in the right eye, and total cynical closure in the left eye, not much of cataract. Fundus showed neovascular on the disc and forehead FPP on the inferior arcade, and a small TRD. Left eye also showed a similar features, and PDR with neovascular glaucoma. Cynical closure in the left eye, but not much of cataract. So we went ahead and did a glaucoma valve implant for her. So because of the cynical closure, a trab wouldn't work for her very long time. So at the end of 6 months, she was 6/9 OU, and intraocular pressure of 17 millimeters mercury, no glaucoma medication. Retina is stable and controlled diabetes. So this is I'll leave you with this chart. We must not forget cycloablation and cyclocryotherapy, and in end-stage disease, we could even consider enucleation for such patients. Thank you very much for patient listening.
Thank you, Dr. Raman, giving the elaborate picture of neovascular glaucoma. I think early diagnosis and early intervention saves the eye. Otherwise, if once it goes to late stage, it's hardly we can retain the vision. So very important. You can manage the glaucoma, you can manage cataract, whatever. But vision usually compromised in late stage. So I think you have to start doing the diagnosing and treating the case early. So
Just
thank you.
One
Yeah.
question, Dr. Ganesh. Both the cases, 1 and 2, had a NBI also. In such cases, sometimes if you do a PI, that might bleed and create a complication. Would you inject anti-VEGF intracamerally these patients to suppress the vascularization?
Sorry, all the procedures were done after VEGF injection. So any anti-chamber entry was done only after VEGF injection.
I think that is a very important message. And second case had a one-eyed patient, had a 26 pressure only. And we know that there are a lot of literature, if you just do only cataract surgery, around 2 to 3 millimeter mercury pressure goes down. And you can maintain with the anti-glaucoma for a longer time in these patients, rather than doing a combined surgery. I'm not a glaucoma surgeon, but
No, definitely,
but
that's one option. But
case.
unfortunately, if it doesn't reduce, he goes back to square one again.
Okay.
The problem is if he develops a corneal edema paradoxically, it's a progressive condition and develops the corneal edema. We won't be able to ablate the retina as well as we would like to.
Okay. Thank you,
Thank you,
Ganesh.
sir.